Morning, everyone. So we are looking at Mr. D, a 29-year-old radiographer from Vellore, who presented to ED in an unresponsive state. So just he's been unwell since the day before presentation. So the day before, what happened was around 8 a.m. in the morning, he experienced excessive sweating and palpitation. A few minutes later, he had sudden onset giddiness associated with blurring of vision and sweating. He was also noticed to be agitated. The wife is a staff nurse who works in our campus only. So she quickly noticed the symptom, checked the sugar. So he had GRBS of 45 milligram per deciliter. So she quickly gave glucon D that she had um, in the home, and following which the symptoms settled, he took breakfast and went back to work. So, and the work, 2 p.m., he was very busy that day. He was saying that sudden onset sweating, headache, confusion, and followed by decreased consciousness. This was noticed by his co-worker. And he had uprolling of eyeballs and tremors as well. There was no tongue bite, involuntary limb movements, or involuntary passage of stool or urine. So they also given glucose containing water, and following his symptoms subsided. That day he was busy and didn't have his lunch. And after that having lunch, his symptoms improved. So the next day morning at around 8 a.m., he walked to the washroom and felt lightheadedness, and he fell down. He was very drowsy and unable to reach the door. After some time, the relatives noted that he isn't coming out. They broke on the door and was found in an unresponsive state. That time also, so quickly they brought him to the hospital. So in the CMC ED, they directly brought here. He was noted to be conscious yet drowsy. His GCS was 10 by. He was not verbalizing, but eye opening and response to pain was there. His GRBS noted at the time was 34. And after giving IV dextrose, his symptoms improved to 88, and he was conscious oriented. So other history. So there was history of weight gain of 10 to 12 kilograms over 1 year. There is no history of renal calculi, pathological fractures, diarrhea, skin discoloration, headache, or vision changes. And past, he does not have any comorbidity. There is no regular medication intake and or CAM intake. And then family also, no one is taking any anti-diabetic medications. He is not a smoker or ethanol consumer. Only significant family history, his mother had Parkinson's disease. So and on examination, actually, positive findings. After coming to the ward, he was completely normal. His sensorium and systemic examination, general examination, everything was normal. So we have a clinical syndrome of hypoglycemic symptoms, and we have documented low glucose value and symptoms that respond well with glucose immediately. That fulfills the Whipple's triad. So our clinical syndrome now is recurrent episodes of hypoglycemia. So the following differentials are considered when he came. So first and foremost, the most common cause medications. Is he taking the exogenous insulin or sulfonylurea? But in history, he does not have any. Second thing is an endogenous hyperinsulinemic process. Third is there any underlying sepsis, adrenal insufficiency? Is there any underlying renal or liver disease? These are the initial differential that were considered. So the initial investigations, the important ones, liver function tests and renal function tests were completely normal, and this random cortisol level and ATM cortisol were also the normal range. Protein investigation, everything was also in the normal. Metabolic causes were also within normal limits. So again, coming back to our differential lists. So sepsis did not have any fever, tachycardia, hypotension, no source. So sepsis is very unlikely in this setting. He's not an unwell patient. After giving the correction, he was very well. And adrenal insufficiency with the normal cortisol levels and no history of weight loss or hiccups. Those history were not there, and no other features suggest for adrenal insufficiency. That also was ruled out. And considering the liver and renal parameters are also normal, nothing to suggest no comorbidities as well. So renal liver disorder, we are fairly ruled out. So considering now these two possibilities are there, medications or endogenous hyperinsulinemia, medication, but historically nothing is there, but we can keep it in the back of it. But endogenous hyperinsulinemia is the one thing that we wanted to evaluate for. So we did a supervised fasting. That is, he came to the ward, he was on continued 10% dextrose infusion. Usually the test done is supervised fasting, where we ask them to fast for at maximum 72 hours. And when they develop signs or symptoms of hypoglycemia, we test them for some parameters. For our patient, though, after stopping the infusion, just 2-3 hours later, he again had symptoms of hypoglycemia, had giddiness, palpitations. So immediately so other things, the endpoints, the cutoff, just a protocol, less than 55 milligrams of deciliter with symptom or without symptom, less than 45 is the time when we take the test, supervised fasting test. And they should consume only beverages that are calorie or caffeine free. and samples to be sent. In our CMC, we have glucose level, serum, that is a lab value, not the GRBS value, but insulin level and C-peptide. These are available in CMC. If possible, we can do a beta hydroxybutyrate oral pro-insulin level and oral hypoglycemic sulfonylurea screen as well. So we had sent the sample when he had had around 30 on the reading, and at the time concurrently we had sent the samples of fasting glucose at the time of 29, and C-peptide level concurrently was 12.4, and insulin was also very high. So the diagnostic cutoff to say it's an endogenous hyperinsulinemia, he fulfilled that criteria. That is clinical symptoms plus glucose value less than 55, insulin more than 3, or C-peptide and C-peptide more than 0.6. That is a point of endogenous hyperinsulinemia. So again, back to our differentials, now new endogenous hyperinsulinemia. Among this, these are the possible etiology: insulinoma or insulin autoimmune syndrome, or some other tumors producing some factors that can mimic insulin, or without insulin, there is just a hyperplasia of the pancreas that also can produce these. But these two are less likely in this picture. Any comments? Why? That is insulin autoimmune syndrome and islet cell hyperplasia. Insulinoma is just a tumor of the islet cells. Or generally, hyperplasia is called islet cell hyperplasia or nesidioblastosis. So these are less likely based on the history. As I want to so his history, basically, he was always. Hmm? So historically, he didn't eat actually. In the morning, early morning, he did not have food. Then lunch, he did not have any food. So his symptoms are predominantly preprandial. That's in a fasting state, he is having symptoms. But these two entities are mostly postprandial. Insulin autoimmune. The insulin autoimmune Hirata syndrome is a very interesting disease where there are auto antibodies produced against insulin. After food, when the insulin start to go up, these antibodies bind with the insulin, and so body will think we need more insulin, keep on producing more, keep on binding. Slowly, these antibodies will dissociate from each other. Sudden surge in insulin, sudden hypoglycemia. So they'll have mostly postprandial. And this nesidioblastosis also is not. It's a response only. It's an excessive response of the insulin to glucose. So that is also not fitting in here. And non-islet cell tumors are also not fitting because they are usually IGF-2 mediated, and they will have low insulin and C-peptide on the blood vessels. So we have high insulin, high C-peptide, endogenous. So the insulinoma pretest probability is increased based on this. So we went ahead with an imaging. There's a localization, and CCT abdomen pelvis with an MRI T2 we have done. This is actually not that patient, but similar image I found on the internet. So we found a arterial phase hyper enhancing lesion in the head and uncinate process of pancreas, and there was most likely suggestive of a neuroendocrine tumor involving the pancreas. Yeah, this area, this hyperenzyme. He also had similar. I have this white color enhancing lesion there. The head was a tumor, and there is arterial phase hyper enhancement of the tumor. So just a brief what we have seen so far, how to differentiate. So as we saw, postprandial hypoglycemia more likely to be insulin autoimmune or a non-insulin pancreatogenous hypoglycemia. That is the nesidioblastosis. Both are mostly postprandial. Our insulinoma and other tumors causing IGF-2 mediated or fasting predominantly. So this can help you to differentiate. And IGF-2 is elevated in NICTH, but in insulinoma it is normal. And auto antibodies are found in the insulin autoimmune syndrome. And imaging finding, only insulinoma will have a pancreatic tumor. NICTH will have non-pancreatic tumor like hepatocellular carcinoma, adrenocortical carcinoma, large sarcomas. These are notorious to cause IGF-2 mediated hypoglycemia. Just a few words about insulinoma. It is the most common functional pancreatic tumor. The age of onset 40 to 50. They're generally small, less than 2 centimeter, and 5 to 15% are malignant. They can occur anywhere in the pancreas, and 4% of tumors are associated with MEN1 syndrome. It was described in 1928 as early as, and it has been very rare actually. 1 per 1 lakh to 2 lakh 50,000 person years. It's very rare tumor. And the important point is the localization, because these patients after enucleation do very well. So, but finding is very difficult. So some of the methodologies you can use are initially ultrasound. CECT has, in this large study done in a meta-analysis, showed us CECT still has sensitivity of 54% and specificity of 75%. Overall, PET-CT and DOTA extendin 4 PET-CT have good localization value. Other invasive methods are currently not preferred. In case you don't get anything, we can do that. Otherwise, intra-op ultrasound also can help in localizing these tumors. And our CMC endocrine department has published 18 patient with insulinoma case series and was published in 2008. Some of the important findings were everyone had neuroglycopenic symptoms, and weakness or dizziness were also very common. Autonomic symptoms. So both autonomic and neuroglycopenic were the predominant symptom. Weight gain. Our patient had weight gain, which was seen in 27% in their cases. So insulin is an anabolic hormone, and they can face weight gain as well. So in our study, CT was shown to have sensitivity of 62% and specificity of 100%. MRI and DSA also, MRI was also had a good yield, 85 and 100. And overall, their survival is very good. This is the largest cohort of insulinoma than in Mayo Clinic, 224 patients. So benign insulinomas actually had almost a similar life expectancy to their peer group in the same age group. Malignancy and metastatic disease is very difficult, and they have early mortality. So our patient, we initially started on diazoxide, 3 mg per kilogram thrice daily, initially 50 milligram per 50 mg thrice daily, with which itself has symptoms actually. The hypoglycemia resolved. We stopped the infusion. He was on diazoxide for 4-5 days. Was completely okay. And finally, we went ahead with the enucleation of the tumor, and it was a well-differentiated benign neuroendocrine tumor with less mitosis and MIB1 index. So he's been doing well. We have been following up for last 6 months. He's doing well. This diazoxide, how it acts, it closes the KATP channel and hyperpolarizes the calcium intake channel, and finally inhibits insulin release. It works well and available in CMC as well. Just a fun fact: this insulinoma actually in 1970s, there is a German patient with insulinoma. They excised the tumor. This person, Axel Ulrich, runs a big pharmaceutical company. So he got the tumor, and he isolated the mRNA. It was infinitely producing insulinoma. So he took it. That mRNA was eventually mRNA was put on a vector they had transferred and to an E. coli. So that E. coli produced the first human insulin. So it's a first cloning of gene was done, and we got our first insulin. This is the first human gene cloning experiments done, and we have our human insulin. That's one fun fact.
Thank you, Narendiran. Any questions from the audience? Yeah.
Yes, ma'am. So historically, he did not have, and if you're suspecting Men1 at age 5, we should start screening in those syndrome equation. In this patient also, we can look for association. He did not have symptomatology suggestive. We did prolactin and other markers also to look for any pituitary tumors associated with it. And thyroid functions are also normal. PTH levels, calcium, these are also normal. It requires screening.
How will you differentiate someone who's taking exogenous insulin? I know they may tell you, but sometimes people historically apparently do take, surreptitiously. So how will you differentiate someone who has exogenous insulin use?
In this case, with the biochemical parameters,
which ones?
They'll have suppression. They'll have low C-peptide levels because endogenous hallmark C-peptide. But sulfonylurea, on the other hand, will have both increased insulin and C-peptide. Only the biochemical sulfonylurea screen will rule out because it also increases the insulin production. So that is even more difficult to differentiate. And we don't have that screen. So supervised fasting, make sure they don't have any medication bedside. I think that should be all right.
Okay, thank you. Any other questions?
So diazoxide, the potassium KATP channels, though it increases, actually potassium comes inside, and it depolarizes the calcium channel. So more calcium intake increases insulin release usually. So glucose does this. Diazoxide closes this KATP channel, so it hyperpolarizes the calcium channels, and it closes. So less number of calcium is available intracellularly, and less number of insulin is released.
It's the same receptor as sulfonylureas work on, I think.
It opens.
It's like an the opposing action to a sulfonylurea.
Pancreas, yes. And that also we can use for localization. So we can give calcium through once we have difficulty in localizing the tumor in specific venous territory. For example, tail of the pancreas supplemental to splenic artery. We can administer calcium through that, and in the output hepatome we can check if it's high or not. Then most likely it is a tail. Then they'll excise the pancreas, tail pancreas. They do well. So that is also selective arterial calcium testing.
Okay, thank you. That brings us to the end of clinical meeting for today. And I'll give this prize for the best presentation to Narendiran.